Hey guys, in this presentation, we're going to take a look at pain assessment tools. As you go throughout this presentation, I want you to remember that this course was intended to be a thought-provoking course. Not so much about coming away with ABC knowledge, but did you somehow grow your brain, figure out a way to apply it to practice, or start to question the way you think about things? So as you go through the presentation, remember that. Utilize the pause, the rewind, the replay as much as you need to think about different concepts as we progress throughout the presentation. So first, let's go through a quick introduction. And I'm going to try really hard not to read these slides to you, so they're there for you to be able to utilize them to get the information off of. So pain scales come in a bunch of different ways. We do verbal, visual, or behavioral scales. The ones we like the best are self-reporting tools, though, because those are the ones that are supposed to be most accurate. Pain is what the patient says the pain is. So in this presentation, we're going to walk through some of the ways you're probably familiar with, but maybe learn something as we go throughout this review about those that you're already using. And then we'll look at some what I think you might find to be new ways for assessing pain. Let's start out by looking at some you're probably familiar with, and we're going to begin with the neonate and go through the adult. So with the neonate, it's the NIPS scale, or the Neonatal Infant Pain Scale, and it was created for newborns to 1 year. You can actually utilize NIPS for premature infants as well. The next scale that we'll look at is FLAC, and it's for infants that are 2 months or older, and it actually was intended for people up to the age of 7-ish. However, you can actually utilize FLAC scale for any age. So if you have a geriatric patient or a developmentally delayed adult, FLAC scale can work for them as well. And as you look at it, you can see it just talks about what does the patient's face look like, what are their legs, their activity, their cry, and their consolability. And then you assign points based off of it. Looks pretty self-explanatory and seems pretty simple, right? Well, let's look at the actual instructions for a FLAC scale and see if we're utilizing it correctly right now. So with a FLAC scale, if your patient is awake, you have to observe them for 2 to 5 minutes to get an accurate pain assessment number. You observe their legs and their body while they are uncovered, and then you should reposition the patient so that you can observe their activity and assess their body for tenseness and tone. If they're asleep, the observation should be for at least 5 minutes and longer if needed. Same concept. You have to observe the body and legs uncovered and reposition the patient if possible so that we can see some activity to assess for tension and tone. Next is the Wong-Baker Faces. And this scale is roughly for a 3-year-old. However, you got to have some ability to kind of abstract think or a little bit of reasoning to be able to utilize it. So some children may be able to utilize this at 2, where others may not be able to utilize it until 4. That's where you as the nurse is going to have to figure out what's most appropriate for the patient you're dealing with. And again, this seems simple enough. But who actually picks the face? Does the patient? Does the nurse or the mother decide which one of these faces is most accurate for the patient? Well, according to the Wong-Baker Faces Foundation, they say that you should explain to the patient what the faces means, and they give you the exact terminology they want you to use here. And then you ask the patient to choose the face that best depicts the pain they are experiencing, making sure you point out that even though the face in 10 is crying, you don't have to be crying to have a pain of 10. And then next is the numerical rating scale, and all of you guys should be familiar with this. It's our most commonly used scale. And this is typically for people who are 8 years or older. However, let's think about this scale for just a minute. Do you encounter problems with this scale in your practice today? Think about what is moderate pain and how you explain that to a patient. What do you do if a patient says they're not able to rate the pain, that it just hurts? What do you do if you have a patient who says their pain is a 15? These are just some of the common questions or concerns that are brought up utilizing the numerical rating scale. So let's look at each one of them individually. First, what is moderate pain anyway? Well, to answer or prevent this question, we could provide explanations for each pain level. Pain of 5 means that you can't perform your normal daily activities, for example, may be what you say. The DVPRS pain scale that we're going to look at in just a minute has great explanations for each level. So even if you don't utilize that pain scale, it gives you some pretty good guidelines to explain to your patient what it means to have pain of a 5. Whatever it is, you want to make sure your patient, that particular patient, is able to understand your explanations. For example, if your routine statement is 10 is the worst pain you can possibly imagine, like having a baby, and you say that to a 24-year-old man who has no concept of having a baby, does he really understand the association? Furthermore, what if you said it to 2 separate women? Is having a baby the same for every woman that you talk to? Is it just as painful for one as it is for another? So think about ways to help your patient understand the level in a way that they can associate with. Next, what do you do if you have a patient who says, I don't know how to rate it, it just hurts? Well, there's 3 tactics we can employ here. We can try to explain to them why an accurate pain number is important. We can try changing the way we explain what each pain number means. And then finally, we could ask ourselves if we're using the appropriate pain scale for this patient, and then adjust accordingly. Now, the last one is, what if my patient says, my pain is a 15 on a scale of 0 to 10? Now, I know you guys have never had this happen before, but on the off chance that sometime in the future you have a patient who tells you their pain is greater than a 10 on a scale of 0 to 10, what do you do? Well, we're going to start with the same basic principles from the previous question. We're going to make sure they understand why an accurate pain number is important. We're going to try to change the way we explain the pain numbers. For example, you might say a 10 is the worst pain you can possibly imagine, like on the floor screaming and crying. And when your patient says their pain is a 15, you can say, well, a 10 is on the floor screaming and crying and you're sitting in a chair, so the pain would therefore have to be lower than a 10. Now, you're going to say that in a much nicer way, however, you get the gist. You explain it in a way that it's very clear to the patient. And then finally, ask yourself again if this is the appropriate pain scale for the patient. And we want to talk about this a little bit further, because twice now I've told you, try explaining why an accurate pain number is important. So stop and think about that for a minute. Why is it so important for the patient to provide an accurate pain number? Why is it so important for the patient to provide an accurate pain number? Really, if you want your patient to understand the importance, you have to understand the importance of this. So think a little harder. Come up with a couple of reasons why you think it might be important for the patient to provide an accurate pain number. Well, let's just start with why it's important to me as a nurse. First, simply put, is it's an assessment. So if I make up a number or I assign an arbitrary number, for example, if I say, what's your pain on a scale of 0 to 10, and my patient says it's an 18, and I record a 10, that's an arbitrary number. That's the same thing as me looking at my patient without a stethoscope and saying they have crackles in their lungs. Pain assessment is an assessment. And that's part of being a nurse. Assessing is the job of the registered nurse. I worked very hard for the right to be able to assess a patient, and I take great pride in what I document as an assessment. So remember, when you document a pain scale, you are documenting an assessment, and you want to make sure it's an accurate one. That's why it's important to me as a nurse, but what about to the patient? How is this beneficial to the patient? Because they really don't care about how hard I work to be able to assess somebody. Does it impact patient outcomes? Do you think that accurate pain reporting would actually improve a patient outcome? So to answer this question, let's go back to where we started with the very first piece of this module. And we remember that pain has a function. Its function is to alert us that there is a problem. So if we're not accurately assessing patients' pain, how do we know when there's a problem? So to illustrate this a little closer for you, let's just take, for example, patient comes into the emergency room, they have acute appendicitis. And so they say to the emergency room nurse their pain is a 15 out of 10. And the nurse is busy. She's working in the emergency room. She's got a lot going on. She's trying to get this patient ready for surgery. So she documents that the patient's pain is a 10. Well, the patient goes to surgery. They go back to the floor. Everything's fine. And 12 hours post-op, the patient reports to the nurse who asked that their pain is a 10. So the nurse documents the pain of 10 and administers the pain medication appropriately. 18 hours post-op, the patient calls out to the nurse's station. They're kind of frantic and they seem desperate, and they're reporting their pain as a 15 to the nurse. Well, so this is a new nurse for the patient. And so she goes back, she's a prudent nurse, and she reviews the record. And she sees that every time the patient's had pain medication, her pain was a 10 out of 10. No big deal, it's the same pain they've been experiencing, and they administer the pain medication and go about their business. But knowing what we know now, are you concerned about this scenario? Could this inaccurate assessment, furthermore, an inaccurate documentation of an assessment, cause a life-threatening event to occur? I'm going to let you ponder that concept for a bit. I want you to think about that and think about what you personally can do to improve pain assessment accuracy in your practice, but also in the facility that you work in. And we're going to come back and think about that thought later. But for now, we're going to go back to the pain scales. So we've talked about basic pain scales that we're all utilizing, hopefully learned a bit of new information. What do you do if your patients don't fit into one of those boxes? Well, these next couple of slides are going to provide a few alternatives to those boxes. The first one is the PIP scale, and the PIP scale was specifically designed for premature infants. So if you're working with that population, the PIP scale would be a great one for you to use. Additionally, we're seeing more and more patients with dementia and Alzheimer's, and assessing their pain can be particularly challenging. So that's where the pain assessment in advanced dementia has come into play. It's a relatively new scale, but one that's available for use as an alternative. Now, the NVPS has been on the rise for the past few years. That's partially due to some recognition by Joint Commission that we needed a better scale. This nonverbal patient scale allows the nurse to assess a patient who's not verbal, mainly because we made them not verbal. So we've sedated them, or we've intubated them and they're not able to talk. This one's great because it also allows for a physiological assessment of the patient and then gives you a number at the end. Now, on the horizon, there's a few new and noteworthy pain assessments that you want to be familiar with. Because at this point, you probably figured out that pain assessment is not a one-size-fits-all type thing. I can't utilize the same pain scale for every patient that I see. The following slides are going to look at two of the newer concepts in pain assessment. And the first one we're going to talk about is the PEG scale. We remember again back to an earlier module, we talked about the difference between chronic pain and acute pain. And so it makes sense that now we understand that these are two separate creatures completely, that we should also have separate tools for assessing them. And that's exactly what the PEG scale does. It assesses chronic pain. So it does take into account the 0 to 10, how bad is your pain type situation, only it looks at it, the P or pain intensity, over the average of the past week. The E looks at how does the pain impact your ability to enjoy life. And then finally, the G is general activity. So how often has the pain interfered with your general activity? The next scale I want to introduce you to is the DVPRS. This is the Defense and Veterans Pain Rating Scale, and it came out of a 2010 task force in the armed forces. And you can see just by looking at it, immediately you notice it looks like a combination of different scales. It's got faces, just like the Wong-Baker Faces scale does. It has the elevations. It has colors. And it has numbers. Additionally, as I mentioned to you earlier, it has a descriptor for each number. And this is the piece down here that I think you might find helpful in your practice, even if you don't utilize the scale. So you can help your patients to understand what an 8 actually means versus what a 10 or a 3 means.